the caption, but we just move on. So let me see if I can move. It's moving, isn't it?
Yes, it's moving.
Okay, let's start. So essentially what we're is the CNS, and I want to talk about investigation of the nervous system. And that's assuming you've done a few of the preliminary, which included localization. But basically what we have is, when you have a nervous system, is what you ask yourself is, one, is there a lesion, is there a central nervous system problem? And if there's a central nervous system problem, where is it? And that is part of the localization. So localize it, it is because the patient has got paraplegia, the lesion must be in the spinal cord. Or because the patient has got dysphasia, the lesion must be on the left parietal lobe or right Broca's area, and therefore, because he has got a speech defect and he's got hemiplegia, that localizes it to that particular region. Now, sometimes, of course, it may be, so that's the basic thing, is where is the lesion? That's the first thing you need to ask yourself, because where is the lesion, therefore, then helps you define what investigations are you going to carry out. And really, there are two types of things which can cause central nervous system issues. One, is it a solely central nervous system disease issue? For instance, you might have some of the brain tumor that is specifically in the brain only, primary brain tumor. Or is it a systemic disease that is manifesting itself in the nervous system? And that may be things like malignancy. You can have somebody see a breast now coming with hemiplegia. And therefore, that means the original disease was actually a breast, which has now metastasized to the brain. And therefore, it's a disease elsewhere which has moved to the brain. And it can even be condition like diabetes mellitus, which can affect, it's a systemic disease, but can have a manifestation in the nervous system. So, or even cardiovascular disease. You may have somebody with mitral stenosis who has a cardiovascular disease but presents with a stroke. So those are the things really need to ask. And investigations have helped you localize, get it much more specific than the physical examination. Because you know that 80% of the diagnosis is from the history. And therefore, it's only about 20% are the ones which you are going to use the diagnostic sets. And once you go to history and physical examination, most of the things have been done. And therefore, from this, like you know from the history and physical examination, you'll come out with a diagnosis and a possible differential diagnosis. And that's why you're doing the investigation. You're doing the investigation because you want to know what is in your diagnostic formulation, rather than do investigations and then once you get the investigation, then you can tie them up. That's a usual thing that is happening now, what we call a gunshot therapy. You come with a headache, all you do is do an MRI, do all the blood tests possible, and then in the end, try to remove each one of them, and that doesn't help you very much. One, it is too expensive, it's too broad. So first thing, you must have a clinical suspicion that this patient has this condition. This patient was presented with weakness of the lower limbs and visual loss, and this has been going on and off. I suspect the patient may have multiple sclerosis. And therefore, when we are doing tests, and we test which are going to help me to get that disease. So it is difficult to make a diagnosis or use or put investigations unless you really have the suspicion. So the investigations, one confirms your suspicion. I thought this patient had this condition, and therefore I have confirmed it by this test. This patient who comes with a headache, progressive history of headache, has a convulsion, has vomiting, I think he has a space-occupying lesion. And therefore, if he has a space-occupying lesion, my suspicion, number one, is somebody who's HIV positive, has been treated for TB. I think probably he has a tuberculoma or he has a tuberculous abscess. And therefore, my test would be going towards this diagnosis. I'm going to image his brain, I'm going to image his chest, I'm going to do this sputum for FBs for diagnostic purposes. Therefore, that is the formulation that you have, which now leads you to the investigation. The other thing is must be cost effective. Investigations are sometimes very expensive, and you might have the utility will go into later on. When do you need a CT scan or when do you need an MRI? And so it must be very cost effective, it must be cost conscious. I know most people is not cost conscious. It's a matter of just writing an investigation and it will be done. So you must look at it, this investigation which I'm going to do. Is it going to help me? Is it the most, is it the one which is going to be the cheapest? Is it the more effective method of investigating this patient? For example, a patient comes with a seizure, and I have to decide whether I'm going to do an MRI or a CT scan. I'll probably go for an MRI because the MRI is going to give me more information. It's going to give me a lesion that the CT scan is going to miss, and it will also be able to, therefore, it will help me, even if it costs about 18,000, 20,000, it will be much more effective at this particular condition. If somebody comes with a, let's say, suspect he has had a stroke just now, then probably a non-conscious CT scan may make sense because it will help you get what you really need at that particular time. If it's a bleed, you'll be able to get a bleed. There's a bleed or there's an infarct. I don't need an MRI then for that purpose. So I think that it becomes important that you don't do a test just because it is to be done. It must be focused, it must also be cost effective, and must also have the highest utility that will be able to help you. And as I said, it must be specific to answer your question. There are no routine tests. I go in the ward round and they say, okay, routine test I've shown. There's no routine test. Each test is tailored towards a particular thing. If I'm doing a hemogram, I'm looking at if the patient has got an infection, I want to see what's the response of the white cell to the infection. The white cell high. So that would be my tech. Rather than doing all the possible tests, just go a nursery rhyme, hemogram, UECs, LFTs, what else you have? UECs, LFTs, blood sugar, what else do you do? Lipid profile, then what else do you need to do? Urinalysis, then you do what? Stool for culture and sensitivity, stool for ovum and cyst. That does not help you. It is very expensive and does not help you. You must have that the test that you're doing is going to answer your question and is going to be the most effective test that's going to help you. If somebody's got, let's say, sometimes you have somebody who's got proximal, we'll go, probably when you get it, you're going to see it. Proximal muscle diseases. Proximal usually means it's a muscle disease. And therefore, my test would be going towards a muscle disease. I'll look at the muscle enzymes. I'm not going to do an MRI of the cervical, thoracic spine, and then find it is normal. Then afterwards, once I've seen that this is a muscular disease, then my investigations would be cornered towards that particular area. I hope that becomes clear. Don't order tests for the sake of ordering, order them to answer your question. Now, one of the common tests that we do in neurology is cerebral spinal fluid. Now, the cerebral spinal fluid is one of the tests that we use for utility. And as you know, the CSF is produced by choroid plexus, is absorbed, and it is a close call towards areas, diseases of the nervous system. And usually, there are several indications for doing a lumbar puncture. And one of the lumbar puncture or CSF studies is to measure CSF pressure. So use it to measure pressure when you do because there are conditions where the pressure is high. We also use it for specimen analysis. So you take a specimen of the CSF for various utility. We also might use it for diagnostic, for other procedures. You might use it for one local anesthesia, but that's not the diagnostic utility. You might also use it, the old time used to use it for myelography. When you put contrast into it, that's probably not very much used now. Using for chemotherapy, that's not the diagnostic. So there must be very clear reason for analysis of the CSF. And usually the CSF is analyzed for the purposes of one, conditions where we suspect there's meningitis. So you have a suspicion that this patient from the history may have meningitis, and we don't know what it is. So you want to do in a patient with meningitis. In a patient who has a very severe headache of sudden onset, we do it because we want to think, does this patient have a subarachnoid hemorrhage? So that would be a utility of that. You also do it in things like, meningitis, acute meningitis, the chronic meningitis. You also use it for condition like, for instance, it's demyelination. You suspect this patient has, let's say, for instance, myelo, multiple sclerosis. And there are certain tests that I want to do in the CSF, which will help me diagnose what it is. And these are, we'll look at it in oligoclonal bands. So you're looking specifically for a particular thing. You might also have it in a patient who presents with, we talk about a headache, you think meningitis, you think about demyelination, you also think about malignancy. Somebody's got malignancy and has come with a headache. So you think, does this patient have meningitis, what do you call them, malignant meningitis? And sometimes you also have other conditions that you might want to utilize. I've said subarachnoid hemorrhage. We're looking for xanthochromia. And some of the condition that you might use it is somebody who comes, let's say, comes with a seizure, and you probably may not be able to localize a seizure. Then you might have to do a CSF study. If somebody has got things like syphilis, you may also want to do a CSF studies. So those are the usual indication. And the CSF is a safe procedure, but you must ensure that there's no raised intracranial pressure or there's no focal neurological deficit. So if somebody's got a focal neurological deficit, CSF may not be the best thing, because if you do the lumbar puncture, then due to the pressure on one side, you can get what is known as coning. That means the brain moves down the shortest cut that you can move out, and that is in the foramen magnum. Therefore, you get coning. So you have to be very certain about that. So what do you do about a lumbar puncture? Of course, one is you must have the clear indication. You must have the equipment that you have, and it's done under local anesthesia. Don't do it under no local anesthesia. It's a painful procedure. And you measure the opening pressure, then you look at the color, and the color, whether it's uniformly blood stained, it can be xanthocropic, it can be turbid, it can be clear, or sometimes you can put it down for a while and you see it becoming a cobweb. If it forms a cobweb, that means it's got very high proteins. If it's turbid, that means it is probably meningitis. And look at the biochemistry. Basically, you look at proteins and sugar. The CSF, you know that when there's inflammation, then the proteins would rise. If there's a meningitis or anything that is there, will start consuming the glucose. And therefore, you'll have low glucose and high protein. That will tell you that this is probably meningitis. You look at the cellular elements, look at the white cell count. And white cell count, if there's more than 5 white cell count in the CSF, that may mean that there's a there's an inflammatory process going on. Usually that's meningitis. And the meningitis, the two types, pyogenic meningitis, or sometimes you have lymphocytic. When you have lymphocytes, that probably tell you these are more chronic meningitis. Then, of course, you look for malignant cells. That will help you know that there is malignant cells will help you if there's a malignant meningitis. Then, of course, we also look for organisms. There are organisms which can be seen. And the organisms include the Cryptococcus and neoformans, which of course will be the Indian ink, which tell you this is a patient that's got cryptococcal meningitis. There are also other things that, of course, you want to do microscopy. You can see, in the microscopy, you can see cells that have engulfed, you can see polymorphs that have engulfed, let's say, diplococci. Then that will tell you this is probably meningitis, meningococcal meningitis, if they're gram negative. If they're gram positive, then that's probably what's called streptococcus, strep pneumo. So the gram stain also be able to help you. You can also do other stains, of course, the cellular elements that include things like Z Nelson stain, which is basically for seeing if there are any AFBs. Usually the utility is very low, but you might get up to centrifuge, then you might get those organisms. So the cellular elements are both normal cellular element and also other elements. You may also use it for chemicals, like we said, chemicals like oligoclonal bonds, what called NMO antibodies. This will get to know more as you go through the other tests, the other diseases. You can do ACE, that's angiotensin converting enzyme levels, which occurs in things like sarcoidosis. So there's a big utility of the CSF. Of course, you have to take CSF for culture. Culture would be both for bacterial organisms. You can also do culture for TB, also do fungal culture. That helps you utilize that investigation. I've talked about other diagnostic, molecular level. Molecular things include a PCR for TB. You also have panels now for meningitis. Sometimes you don't need to have only one. You also have panels for encephalitis. So there are panels that will help you if the patient has got encephalitis. We want to know, does he have herpes simplex? Does he have this? Or does he have the other one? Usually these are done as a panel. Some of them are called like BioFire, which contains more than 10 or more than 20 different organisms. And I think the other said is it is probably much more, is better if you had a CT scan prior to a lumbar puncture. Now this is just tells us some of the tests and the results. Normal, they said is 7 to 18. With bacterial, then the pressure is very high. If viral infection is normal. Subarachnoid, of course, is increased. The appearance is clear and colorless. Bacterial, of course, is turbid. Viral is clear. Subarachnoid is bloody or xanthochromic. Proteins is normal. Normal, of course, increased in bacteria. In viral, it is normal or decreased, and subarachnoid, of course, it will be increased because the red cells are there. Then the glucose, usually in meningitis, is decreased, and usually that is 2/3 of the serum glucose. So you, at the same time when you're doing the CSF glucose, be sure that you run the serum glucose. So they are low in bacteria, but normal in the other conditions. Gram stain, as you have said, that helps you know in the bacteria because we cannot gram stain the viral. Then white cell, like I said, if it is normal, it's less than 5. If it's bacteria, it's more than predominant neutrophilia. If it's a viral, then the lymphocytes And if it is a subarachnoid hemorrhage, there's increased bleeding. So you might see a lot of red cells. So that may help you as a utility of the CSF studies. There are other conditions that we use for investigations, and it includes general biochemistry. And biochemistry, basically, you should be clear what you really want to get. And it may be certain things like muscle enzymes. If you are suspecting that someone has got a muscle disease, then do muscle enzymes. If you are suspecting metabolic disorders, that will look at it. There are various genetic disorders which are metabolic disorders. So you might want to know which metabolic disorder do you have. Especially, this is much more of utility in a pediatric age group, where you might get somebody's born with abnormal morphology, and you want to utilize that. We'll go into that in more details. The genetics, I think we'll go also into that, and of course, inherited diseases of the nervous system. Those are part of the investigation that you need to do. So you have certain immunological tests that are also of utility in the nervous system, and they help you make certain diagnoses, like acetyl receptor antibodies, which is an antibody, which helps you make a diagnosis of myasthenia gravis. You also have some autoimmune disorders, like NMDA, for example, that is involved in encephalitis. So you have then you have things like a MuSK, which is also involved in, you may get patient myasthenia gravis, but they are negative for that MuSK. Then you have the group of peripheral neuropathies, and you have the group of other antibodies, extracted nuclear antibodies, which are specific for certain, mostly are the paraneoplastic conditions. So there are paraneoplastic conditions that you can use, like the RU, and they are all associated with certain malignancy and certain conditions that occur. Like somebody, they see a bronchus with cerebellar disease, you may have, they call it Hu, anti-Hu antibodies. This may be up beyond the scope of your level, but just remember that there are those autoimmune disorders that are there. You also have autoimmune disorders like when you have conditions like muscle diseases. You may have things like dermatomyositis. That's, I think, the lectures are going to be, where there are very specific antibodies that you'll have which corresponds to that condition. So you have antibodies which help you diagnose a condition. So, but first you must know, what am I dealing with? And then from what you're dealing with, therefore you focus it on one particular part. Am I dealing with the muscle disease? Therefore I do the muscle enzymes. And even if it's muscle enzymes, am I dealing with the primary muscle disease, or am I doing with paraneoplastic disorder? And therefore do the test that are related to that particular area. Genetic testing has become a very important part of neurology. And the genetic tests all range from prenatal now, chorionic villus sampling, then plus you can also do those ones for the purposes of getting genetics. There are also genetic screening upon delivery to screen for other conditions, phenylketonuria, for instance, that is screened through the urine. So there are many areas of utility of genetics. And genetics ranges from all the major ones, like the chromosomal abnormalities, which are major chromosomal, like ranging from Down syndrome, because Down syndrome, you must have you must have a genetic foundation to say this is Down syndrome. Turner syndrome, which is XO, or Klinefelter syndrome. So there are a lot of other conditions which are due to chromosomal abnormality. A lot of those morphological changes that occurs due to chromosome. You might have point mutations, and point mutation is like things like what? Sickle cell disease. If you have sickle cell, then you must have a suspicion that this is what it is, and therefore you do the test. You may not look for the chromosome abnormality, but you can look at the result of this loss of the chromosome. You might have things like muscle diseases, like Adler's disease, Pompe's disease, those when you read in biochemistry. And those ones would require a genetic component to them so that you know there's a the gene is this and this. All those lipid storage diseases, Hunter syndrome, Gaucher's disease, Hunter syndrome. So those all require a genetic component. Now the genetic component is very difficult to do because for one condition you can have very many genetic, but what is done now is have a panel. So you have a panel, okay, if I have somebody's muscle disease, then I look at this panel. If somebody has got mental retardation, then look at this panel. If he's got convulsions, then I look at this panel. So panels helps us to do and refine certain tests because the genetic tests are very, very expensive. Of course, the ultimate is what we call whole genome sequencing, where they look at the whole genome of because you have already been able to analyze the genetic makeup, the genomic sequence, and therefore you can all do a whole genome sequencing and therefore know where the problem is. Because this is very, very expensive. So utility of genetic testing is in condition that you suspect, but it's better to use panels than using this genetic abnormality. And the panel usually picks the most common going downwards. So like I said, sometimes you might have a disease that is systemic, so systemic disorder, and that requires, like I said, very specific. If it's a hemogram, you do a hemogram and know why you're doing the hemogram. If you're doing a lipid profile, somebody's had a stroke and comes to you and you think this is an important thing, then you can do a lipid profile. You can do blood cultures. The blood cultures occurs if somebody has got sepsis and is confused. So do blood cultures specifically. Malaria parasite, somebody who comes with confusion. Other infections. So the other infections which therefore require diagnostic tests, which are diagnostic for a systemic disease. We also have connective tissue screening for diseases that you think like SLE, systemic lupus erythematosus, or rather vasculitis. So this vasculitis may be important to do tests that is systematic, is in the system, but able to focus and help you in the particular region. I think this will get much more when you're doing the tests, the systems. Now, one of the areas that we usually use is utilities imaging. Now, imaging can be of various types, can be a CT scan. That's the commonest, which is easier. This is one of the commonest ways of imaging. You have ultrasound, which is uses ultrasound for soft tissues. You have MRI, which is the magnetic resonance imaging. You have things like radioisotope scans, which are now becoming more of utility. You have things like angiography, which are part of the imaging. So each one of them is useful for any particular purpose. Now, CT scan is probably the most common test that you'll come across, which basically depends on the X-ray being attenuated by tissues. And you get various shapes depending on the atomic number and the physical density. Usually they use a contrast. Iodine was used to, but now you have other contrast, which are opaque. And by being opaque, they're able to help you if you want to localize, let's say, blood vessels. And utility is very important for trauma, strokes, as a first test that you want to do. And basically, a CT scan, it looks like that. You can see there are various densities. The calcium, so the calcium is the most dense. So you can see that that is that's calcium, that's the bone. Then you have water, less dense. Then you have calcification. This is like here, the choroid plexus are calcified. Then you have the water, which is in between. Air is the most dense, most blackest. So, and then the brain itself, you can see gray matter on the outside and white matter. So it helps you in most of the diagnostic. I'm not going to go to each of the diagnostic tests, but this helps you to be able to know what it is. So it will depend on the density. So you should not get, if like blood has got iron. So blood would be dense close to calcium. So if there's a bleed in the brain, you'll see that area is dense. If there's water, then the area would be that particular area. So that's the CT scan. I don't want to go into any particular details, but not knowing that this is part and parcel of the most important diagnostic test. Then you have the MRI. MRI is called magnetic resonance imaging. So what it does is the image varies according to intensity of radio wave signals which come from the tissue, where hydrogen ions have been excited by radio frequency pulse. So what is done, the patient is placed into a magnet. So the magnet, like you realize, is a strong magnet, and therefore the hydrogen ions or water take a particular position. And then a radio frequency is administered. Now, depending on the intensity of water or hydrogen that is there, you'll get different signals. And from these different signals, you'll be able to then do the imaging of the brain. So this is different from the CT scan, which is basically X-ray passing through different densities. Here it's a magnet, which brings in the iron hydrogen ions in a particular frame, and therefore then you're giving radio frequency, and this radio frequency, which is administered, now depending on the amount of hydrogen that is there, will give you an image. Those are other things which are difficult, time to window, time to repetition. Those are difficult ones. Then you have something which the contrast. Usually have a contrast. The contrast is basically to gadolinium, because its contrast helps you look at the picture much better. I'll give you the pictures. The basic thing that you have is what we call T1, T2, and flare images and diffusion weighted images. When I show you the picture, maybe it'll make sense. So this is the picture of various scans. And I think at this moment, it's just a matter of just knowing, you get to know it much better. Now there's what we call T1. Now T1 helps you know the anatomy. And T1, you can see the CSF is black. You can see the gray matter, and you can see the white matter. So that is called as T1. Then you have the T2. Now T2, the only difference is now the water the CSF now appears to be white. And this helps you know the pathology. Because if there's a water, if there's a lesion in the brain, the lesion in the brain which causes swelling, then the area would contain, they'll have a lot more water, and therefore you can see this is the area of edema. That's T2. You can also have T1, which is with contrast, like that one is a T1 with contrast. Then you have what is called a flare. Just no flare. Now the flare looks very much like a T1 because the CSF is black. But it's also good as a T2 because if there's any area of the brain where there's any swelling, there was a blood-brain barrier is broken, you'll be able to see that. So you have a T1, then a T2, then usually there's another one, can give contrast, there's another called diffusion weighted. Now diffusion weighted is good for areas like a stroke. If you get a stroke, it shows you the amount of diffusion that has occurred. So the diffusion weighted images is useful in strokes. But I think the basic thing that you have to know is that the MRI uses magnets, MRI uses radio frequencies, and MRI gives you images which are very close to what reality is. And the basic patterns that you have to remember most often is a T1, where the water is black, T2, where the water is white, flare, where the water is black, but the brain is like a T2, and the diffusion weighted images. I think this is just introduction. Just know about it. You may not utilize it all at the moment. We just want to run through some of the investigation that you need to carry out. Of course, there are contrasts that are given for vessels. So you may look at the blood vessels of the brain, both the arteries and also the veins. So you have what you call as MRA. MRA tells you about the imaging of the arteries of the brain. Then you have what you call MRV, which tells us about the venous consequences, venous drainage in the brain. So that is a MRI, just in a nutshell. Then there's angiography. Angiography is basically looking for the blood vessels. So I've got a suspicion somebody's got let's say an aneurysm bleed. And therefore I do an angiogram. There are various types of angiograms. The angiograms that we talked about, you can do a magnetic resonance angiogram, which is, you can also do a CT angiogram. CT angiogram means you do a CT scan and you give contrast. Then there's what you call digital subtraction imaging. This is really getting the contrast into the brain blood vessels, and therefore then there's digital subtraction, means that you can be able to remove the bones. So the bones don't cover it anymore, therefore you just have the blood vessels. This is probably the best one that you can get, digital subtraction, but the only thing that sometimes it requires much more invasive. Sometimes you have to get in and catheterize the artery and therefore give contrast. So this may not be the most cost effective, but it is sometimes important if you have conditions that are important to diagnose beyond the MRA, CT angio. But in terms of utility, MRA, then followed by CT angio, then the digital subtraction imaging. Then you have radioisotope scans. These are radioisotopes are probably not very much utilized, but they help you in terms of using some tracers. So you put tracers, and these tracers sometimes are they're with glucose. So they go and target a particular area. So you can put those tracers and know this is the area, especially like now Alzheimer's, they're called beta amyloid. You can go and be able to get where the amyloid disease is. So now in terms of Parkinson's and all those In terms of Alzheimer's, you can be able to do that. Even Parkinson's, you can label dopamine, and dopamine you can be able to see the amount. So this is an area of utility that is continuing on being used in terms of one diagnostic. They're also used in terms of utilization of glucose, because like in when they're doing when they want to do somebody's a seizure, sometimes they want to do what they call an ictal spect. An ictal spect is that you do it when the patient gets a seizure, and therefore you can localize a particular part of the brain that the seizure is coming from. So that's the future, SPECT, and PET scans. Those are all imaging. Ultrasound, basically for the arteries, Doppler ultrasound for the artery, which both shows you the artery and also shows you the flow. There's a new area of neurosonography, which now consists of even muscles. You can ultrasound of the muscles. You can do ultrasound of the nerves themselves, so that you can see the nerve, a particular nerve, and you can see this nerve is being compressed in this particular region. Because when it's compressed, the area which is compressed is thinner, then back is a backflow, therefore that is thicker at a particular area. But this is an area that is changing, that is increasing. We don't have it here, but I think it'll be coming soon. So it will image for you the nerves, it will also image for you the muscle, and also image for you the tendons. Then you have the neurophysiology. Neurophysiology is using neurophysiological tests, and usually we use them. There are two main areas we use to call electroencephalography. Then the other one is nerve conduction. The other one is electromyography, and then there's something called evoked potentials. Now, the EEG is an electrical activity that you use to measure electrical signals in the brain. So you put several electrodes on the head, and from the potential difference between the two, you get waves that can help you localize the area of which is important for you to localize. And these are usually for seizures. So for seizures, we usually use EEG. When there's altered levels of consciousness, that's EEG. Epilepsy, EEG. Something like brain death can also be, we can also use EEG to be able to know there's any brain activities. They help you also localize focal brain lesions. So there's an area where there's a focal brain lesion. Also encephalitis, various encephalitis can be utilized. You can utilize the EEG. There's something called SSPE that occurs basically in children with measles, subacute sclerosing encephalitis. There's a herpes encephalitis, which gives you particular lesions, particular waves when you do the EEG. I think you got one or two. And EEG, of course, you have to know I don't want to get you to look at this, but there are waves which are known as alpha wave, beta wave, theta wave, delta. Delta is the slowest. And each one of them must be in a particular area. The alpha usually they are the back of the head, so in the posterior. So you should not expect to see the waves, the delta waves in the posterior, because alpha waves corresponds to vision. So if you close your eyes, usually if the eyes is closed when the alpha waves. But if you see alpha waves in the area where, delta waves in the area where there's supposed to be alpha, something's wrong in that particular region. So they help you localize. I don't have to go into those ones. And there are abnormal patterns, which I don't want to go into. But one of the things that we have is slowness, spikes. Those are sharp waves and spikes. Then you have what we call periodic spikes, which occurs in a particular period. I think that would probably just be all that you really need to get. This is a EEG, which shows you what called as generalized seizure. So you can see in the middle there are certain waves. There's what we call a spike and a wave, like that particular area. That area is clear. So even you can see that the spike starts, then outside get quiet, then it becomes what we call generalized. Generalized means it's in all the leads. There are several leads, about 32 leads, and when it is in all the leads, we call it generalized. If it is in part of the leads only, we call it focal. So it's a utility that can be used for the purposes of diagnosing seizures. Then you have what we call as EMG and nerve conduction studies. And EMG helps you in terms of diseases like peripheral neuropathy. It also helps in terms of where there's a nerve injury, where there's muscle weakness, and when you have a neuromuscular junction disease or entrapment neuropathies. So what do you do? The nerve, I'll probably show you that there. I think that's what is a nerve conduction. So usually have what we call active and reference. And an electrode is used to stimulate the nerves at one point, like there. Once it's stimulated, there's a peak that occurs. This is the ulna, for instance, the ulna. Then there's another stimulation at a particular other side, and that gives us the next wave. Then you do the third one, and you get a next wave. The wave should be the same. Then the next thing that you want to do is, one is from the stimulation to when the electrical, that is known as latency. And that helps you know, usually tells you that the speed of conduction. If there's something like demyelination means that you have lost the lining, then that is delayed. So instead of being where it is, it will be somewhere else. The other thing that you measure is called amplitude, which is the up, how big it is. The amplitude depends on how much of the muscles are stimulated. And you find that if you have what we call axonopathies, which is a problem in the axons, therefore you get that the amplitude goes down. So probably just remember low amplitude means axonopathies. Then there's a distance that you measure, like there and the next stimulation, and you measure the distance between one and the other. Now, when you measure the distances, you want to know the speed. Now, the speed also helps you know what it is. If there is demyelination, then there's slowing of the process. So the conduction is going to be, the speed is going to be slow. And therefore, you can be able to know if there's demyelination, one, what you call as a distal latency is prolonged, two, the slowness in the in slow conduction velocity. And that's what I talk about, distal latency. And we have sensory, so we put motor and sensory. And what in the end occurs is, one, we have conduction velocity, which we've talked about, amplitude, which I've talked about. Then there's another wave, which is known as the F wave. The F wave is just done by stimulating stimulating in a different way. So now it's stimulating backwards. So the stimulus points upwards. So it stimulates a nerve and it goes up to the spinal cord and comes back. So just know something about F waves. I don't think you need to know more than that. But those are helpful in diagnostic for nervous system. The other one that we use for diagnosis is called repetitive nerve stimulation. Now, repetitive nerve stimulation is you utilize an electrode and then you stimulate the muscle at a fast rate, usually about 3 hertz. And when you stimulate the muscle, if it is a neuromuscular junction like myasthenia gravis, you'll find that as you stimulate, it gets less and less and less and less. If it is Eaton-Lambert syndrome, which you're going to lead through, it does the opposite. And as you stimulate, the amplitude gets bigger. So there's one is decremental, the other one is increased. Now, this is a summary of some of the things we talked about. The basic two things, demyelination and axonopathy. And we talked about distal latency. We talked about amplitude. I hope you're going to get these slides. We talked about F waves, conduction velocity, and those will help you know this is likely to be axonopathy versus demyelination. Then you have the EMG. EMG is basically EMG is basically you take a needle and you inject it into, there's an electrode which is injected into the muscle. And by getting injected in the muscle, you can see the muscle movement. So you have what is called as insertional activity. All muscles are supposed to be quiet. They're silent. Then you ask the patient to move. If they're not quiet, then there's something wrong. Usually, if they're not quiet, there's something happening. There may be denervation. So when there's denervation, therefore the muscle is not quiet. It starts moving without even a stimulation. So that is denervation. Then there's something called recruitment. Recruitment is how much, when you move a muscle, it's how much of the motor units are involved. And usually if you have the motor units are in muscle diseases, you have to involve a lot of motor units. So this recruitment is early versus the other one. So if it is the innervation, then you get late recruitment. But those probably are just important for you to just realize that. So then you have a normal, denervation, or myopathic. I think that is, I think that's what I wanted to share with you. I think there was a question that asked about CSF or meningitis. Sometimes you do it for meningitis in case you suspect that the patient may have encephalitis. So that's when you do it in somebody who's got seizures. Any other questions? I know it has been a long sequence, but I think it's just a matter of snippets of investigation. Do you have any other question? I think we have about 1 or 2 minutes. Somebody can put it in the chat box or ask directly. Any questions? Yes. What causes the muscle movement despite denervation? Now, when you denervate a muscle, usually muscle has, if you remember, there were the alpha waves which goes to the muscle, Also the delta waves, which are inhibit the muscle from firing. So once you denervate a muscle, then there are several things that occurs. One, the muscle starts apart from wasting, there's also they start what we call the fibrillation. So they start moving on their own. You can have fasciculation. That means a fascicular muscle. I can give example, those who have participated in the process of slaughtering a cow or an animal. You might find that when the cow or animal has been slaughtered, you still see the muscle twitching. So the muscle is twitching not because it's got a supply, but because it is denervated. So if you have a muscle that is twitching and is not quiet, that is evidence of denervation. Hope that makes sense. I think there's some question, morning if a disease affects I think there's something called SPECT scan. Now this, when you want to do epilepsy surgery, it has to be very clear where the source is. It has to be localized. And the localization is one through the EEG, helps you localize this particular area. Some of the localization are electrical rather than physical, anatomical. So it may be sometimes you can get an anatomical area or an electrical area, but sometimes you want to be able to use, because when there's a seizure, when the seizure starts, the utilization of glucose in that area becomes increased. So now have increased utilization of glucose in that area. If you have a marker which is marked with glucose, then you see an increased activity around that area. Of that to be able to tell you. So usually it's called as ictal spect. Ictal means that it occurs when the patient has a seizure. So some of them have frequent seizures, and therefore when you have a seizure, give the contrast and be able to know this is where it is. But if the patient not having a seizure, you may utilize it. But this is for the purposes of evaluation for, when you're evaluating for the purposes of seizure. Am I getting another question? I think I've answered the questions which are on the chat box. Okay, if there are no questions, then we'll share the slides. I think probably somebody's recorded the slides, and therefore we can all utilize it. Thank you very much.
Recording stopped.
Thank you, Professor Amayo.
Okay.